Hello, my name's Helen Allett from the Liverpool School of Tropical Medicine. This lecture is about maternal sepsis. And our learning outcomes are to define sepsis and severe sepsis, to recognise sepsis by understanding vital signs and early warning systems, to practice an effective response to a woman with sepsis, to review specific conditions that cause sepsis, and to achieve competence in these skills. So sepsis in maternity. Sepsis is defined as a life-threatening organ dysfunction caused by a dysregulated host response to infection. So in our case, the host would be the mother, and she will be suffering from life-threatening organ dysfunction. And this may involve more than one organ, very often does. So we can gauge organ dysfunction using something called a sequential organ failure assessment, or a SOFA score. And if someone scores 2 or more with a change that's due to infection, then they are said to be suffering from sepsis. If sepsis is not treated promptly and adequately, it's quite possible that it will develop into septic shock. And septic shock is defined as someone who has a vasopressor requirement to maintain their mean arterial pressure at 65 millimeters of mercury or more, and that despite having had adequate fluid volume replacement. So a vasopressor requirement means that somebody is needing drugs, perhaps adrenaline or noradrenaline, some sort of drug that can keep the pressure up, and that they need that to maintain their blood pressure at a level enough to allow the delivery of oxygen to the tissues. So sometimes when people present with septic shock, initially they may be very fluid depleted, but the true definition of septic shock is that they remain hypotensive despite having had adequate volume replacement and resuscitation. And if you can measure their serum lactate in their blood, then it will be more than 2 millimoles per litre. But it might not be possible to measure serum lactate in some settings, so you may have to go more with the clinical signs. If septic shock is suspected, it must be treated very quickly, or else it will become irreversible and result in maternal death. So the SOFA score, which I'm not going into now, is quite long and complicated. So this chart is called a MEOWS chart, which is a modified early obstetric warning chart. And this is a way to score patients on the basis of their observations, of their vital signs. So you can see in the columns going down, we have date and time, and then respiratory rate and a score, pulse, a score, systolic, blood pressure, diastolic blood pressure, and they're scored separately, temperature, conscious level, and urine. It might be that urine hasn't been or is not being measured, and in that case, then the urine will be omitted from the score. But you can see at the bottom, there is a kind of grid that shows you how many points each of the various observations attract depending on what they are measuring. So you could see, for example, if somebody had a respiratory rate of 22, they would score 1. Or they had a pulse of 120, that would score 2, and so on. And then as you go across, you add all the scores up and you derive a total score. And at the top it says, well, if the score is 0 or 1, you can safely repeat the observations 12 hourly. But if the score's 2, then a repeat is required in 30 minutes. And if the score is 3 or more, then care should be escalated to more senior staff, in addition to prompt first aid measures being taken by the person involved. So this is a way of assessing the overall condition of a patient using their vital signs. And as the score changes with time over the course of different observations, you can see if they're getting better or getting worse. So that column second in on the right hand side, the total score, you should be able to look down that and you should be able to say, well, the score's got less, that means the patient's improving, so we're doing the right thing. Or you might have to say, well, the score's got higher, and therefore perhaps we need to alter the management somewhat. So it's a way of keeping track of management plans and the effect that they're having on maternal well-being. The reason I'm talking about this is because it's absolutely key that we recognise sepsis and recognise the signs of sepsis promptly, and they can be quite subtle, and if we don't put all the vital signs together we might miss some. In particular, things like respiratory rate is extremely sensitive, but it's perhaps the sign that we pay the least attention to. So to have sepsis, we must first of all have an infection. So there's many different types of infections. Could be a chest infection, so there could be cough, could be productive of sputum, could be chest pain, or there could be some abdominal infection with pain and maybe diarrhea, or there could be intrauterine infection with uterine tenderness. A urine tract infection may cause dysuria, or renal pain, loin pain. Could be tonsillitis with a sore throat and a rash. That might be a streptococcal infection. Headaches could be a sign of meningitis, or cellulitis and wound infections, or septic arthritis may all be localized origins of a more generalized infection. Offensive lochia or liquor again can be a sign of an infection in the uterus, and rigors are a general sign of infection. So with any of these present, we would do our Q-SOFA score, and remember the respiratory rate is either greater or equal to 22, and that attracts 1 point. If it's less than 22, it will not attract a point. Systolic blood pressure is less than or equal to 100, so if it's higher than that, then it will not score, and the mental state must be less than alert in order to attract a score. So once you've got a Q-SOFA score of 2 or more, then you know you've got a situation where there's sepsis, and this demands an immediate response. So we talk about the sepsis 6, and these are things that we really need to do within the first hour that we encounter the patient, and we do as much as possible as we can in the setting in which we find ourselves. So if you have oxygen available, certainly give the patient oxygen. People who have sepsis have an increased metabolic rate, and they require more oxygen. They require more fuel to cope with their increased level of metabolism. They will all need fluids and will need fluid resuscitation. It might be that they've lost a lot of fluid because of vomiting, because of excessive sweating due to fever and the increased metabolic rate, so they will always be behind on fluids and need fluids. And absolutely key is to give intravenous broad-spectrum antibiotics as early as possible. You won't know for sure what the bacterium is that's causing the sepsis. You may never find out. And that's why we use broad-spectrum antibiotics to treat as much as we can. We should start monitoring urine output so that we're able to see the effects of fluid resuscitation and to gauge how well the kidneys are functioning and to guide our future fluid management. If possible, take blood cultures and other specimens, swabs, urine and so on, to send to the laboratory to look for specific infections. It's worth saying, however, that these results, if available at all, will not come back quickly. It may take several days, for example, to get a blood culture result, so we don't wait to treat, we treat immediately. Sometimes if a patient isn't improving, and then we can have results from cultures and swabs and sensitivities to specific bacteria, we may find that we can achieve a further improvement by altering the medication slightly, but it's best to start with straightforward broad-spectrum antibiotics. And then blood tests, depending what's available in your facility. But broadly speaking, we would look to do a blood lactate, urea and electrolytes to assess renal function, liver function, tests for malaria and blood clotting tests, and of course a full blood count. You might want to consider adding an anti-malarial. Sometimes it can be extremely difficult to tell between cerebral malaria and meningitis, and it's safer to start treating both and then refine your treatment once further information about the diagnosis becomes available. There may be an increased risk of blood clotting, particularly in dehydrated patients, and if available, you may want to consider giving low molecular weight heparin as a prophylaxis against this. And then, if the patient is still pregnant, you may need to think of delivering the baby, or if she's delivered, perhaps evacuating any retained products in the uterus that might be a source of infection. So if you're in a basic emergency obstetric care facility, start as much of the Sepsis 6 bundle as you can, and then transfer the patient to a comprehensive facility, having constructed an SBAR transfer, so situation, background assessment and recommendations. And we've spoken about those in other lectures. But do as many of the Sepsis 6 bundle as you can. If in a CMOC, you might be able to do a little bit more, and you might be able to monitor the delivery of oxygen, and you should aim for saturations between 94 and 98%. The basics remain the same: fluid resuscitation, antibiotics, monitoring of urine output, and then those blood tests that we spoke about, and cultures and swabs and so on, looking for the cause. But we don't wait to find the cause before we treat. We'll treat, as has been mentioned, with broad spectrum parenteral antibiotics, and usually a combination of ampicillin, gentamicin and metronidazole will cover almost all bacterial microorganisms. Many places like to use cephalosporins, and that's certainly all right to do so, so something like ceftriaxone, but this may not be available, and there's often cost implications. Once the primary survey and the Sepsis 6 has been started, then you can conduct the secondary survey. And the point of this is to find the cause, the source of the sepsis. So we're going to do continuous monitoring involving ABC and our early warning scores, and then do a systematic examination and take a history. And the examination should be from head to toe. And then we'll be able to tailor our treatment to the cause, because sometimes surgery is also required to treat cases of sepsis. And we can remember that sometimes there are less usual presentations in cases where there's some immunosuppression. So this is just a way of classifying causes of sepsis to help us work out whether surgery might be required or not. So, for example, if there's infected retained products in the uterus, those need to be removed, or if there's a wound abscess, whether it's in the abdomen following a caesarean delivery or on the perineum, or a pelvic abscess. So pus needs to be released from abscesses. There could be other surgical sources of infection. So a patient might have appendicitis, or they might have a different abdominal cause, for example, a gut perforation secondary to a typhoid infection, or there could be a breast infection or abscess. So with all those surgical types of sepsis on the left-hand side of the slide, you will need to operate on the patient to make them better. Antibiotics by themselves will not be enough. With non-surgical sepsis, then we are not able to operate. So, for example, endometritis. Now, it's true that it's quite often fairly difficult to tell the difference between infected retained products and endometritis. So if an evacuation is performed and nothing is found, it might have been a case of endometritis. Other types of non-surgical sepsis that are not directly obstetric are, for example, meningitis, pneumonia, tonsillitis, thrombophlebitis, cellulitis, or pyelonephritis. So all those causes need antibiotics, but we are not able to operate in cases of, for example, pneumonia. There is no surgery to be done. So it's important to think about finding out the cause of the sepsis, the source of the sepsis, to help us understand whether this is a patient who needs surgery of some sort or another in addition to antibiotic therapy. So as we think about the causes of a fever in pregnancy, we must think head to toe, because there are many different causes, and I'm not going to go through this list, but you can see there all the different types of source of fever that there might be. And then after delivery, there are some additional causes, so perhaps pelvic sepsis, wound infections, and mastitis or breast abscesses. So if the lochia is offensive and the uterus is feeling boggy, not nice and firm and contracted, and is tender, then there may be either endometritis or infected retained products. And this is very common. So we should consider with any postpartum fever, especially after a caesarean section. But of course, we won't assume necessarily that it's endometritis until we've done our head-to-toe examination. So we're going to look for symptoms including abdominal tenderness, fever, foul discharge, and increased bleeding. If endometritis is not treated, it might progress to a pelvic abscess or peritonitis, or even septic shock, and in the longer term, a chronic pelvic infection with infertility. So it's very important to treat. There's also a risk of a secondary postpartum hemorrhage if endometritis fails to be treated. So we're going to treat with parenteral antibiotics until the woman is fever-free. If she continues with a fever for 72 hours plus, then we need to reevaluate and consider changes to the antibiotic regime. If you're not sure whether it's endometritis or retained products and the patient is not improving with antibiotics, then you need to consider a careful evacuation of the uterus surgically. Abdominal or perineal wounds require thorough cleaning. Remove the subcutaneous sutures, drain and debride. Any pus should be drained. Any dead tissue should be debrided or removed. And then a sterile damp dressing is placed in the wound and replaced every 24 hours. And you should not resuture while active infection is present, because it will only break down. Better to let the wound heal by secondary intention. For superficial wounds, you can treat with ampicillin and metronidazole only, but if the infection is deep and particularly involving muscles and causing necrosis, you may need to give penicillin, gentamicin and metronidazole. Necrotizing fasciitis is very serious but also very rare, but it does require surgical debridement of the dead tissue, otherwise it will not heal properly. Thrombophlebitis, this is important to remember because people can be on intravenous lines for long periods of time and the line can become infected, so there will be an inflamed site and tenderness along the line of the vein, and there may be fever. So it's important that we resite intravenous lines regularly and avoid them remaining in situ for long periods. You could treat in the postnatal patient with NSAIDs and also antibiotics as necessary. So that's just a few of the common issues surrounding sepsis in the mother. It's very important, in recapping, that we always treat sepsis if we suspect it. Many women die from people not noticing or being aware that they are suffering from sepsis. And the way we're not going to miss it is if we pay proper attention to the vital signs and perhaps do an early warning scoring system to emphasize any changes in the vital signs. And we should then be able to identify people suffering from sepsis early, because early treatment using that Sepsis 6 bundle is absolutely key to them making a good recovery. In low-income settings, not all of the Sepsis 6 may be available, so do what you can. And remember that in some cases of sepsis, surgery is required in addition to broad-spectrum antibiotics. Thank you very much for listening.